it's not even a new field. It's just a field that people are actually paying attention to now, especially now in pandemic mode. Like, I think some statisticians are going to be putting suicide as one of the top 5 leading causes of death in adults. If you want to have a lot of other guy coworkers, mental health, there is a ton of dudes that work in mental health and in emergency. I'm Josh. I've been working, I'm just going to say in the medical field in general for the last 3 going on 4 years. I've been a nurse for almost 3 years. Well, almost 3 years. It'll be 3 years in October. So we're still a little bit away. Pretty close, pretty much close enough, right? Excuse me. And so the first year in my medical field experience, I was actually what's called a behavioral health assistant, which is essentially a mental health CNA with a lot of differences, because I mean, you don't change patients and all that stuff. You essentially make sure the patients don't fight and make some weird things going on in patient rooms. So I did that for a year. I had a lot of fun with that. And then after that, I went to being a nurse in October of 2018. Yeah, 2018, I switched over to being a new grad on the unit. And yeah, so my specific specialty for mental health was child and adolescents. I always had fun with child and adolescents. Then also I'll even add a little sidebar. I was also a mental health clinical instructor for a year for Point Loma as well.
Oh, wow.
Yeah, Dr. Lambert had been grooming me to be one of her minions for a while. So I thought even it was a mental health instructor. That's kind of a little bit of my nursing background.
What sparked your interest in the mental health field?
Well, actually, mental health I've always kind of been around, whether that was doing outreach or even with some of my friends, because I did have a couple of friends that in high school, they were having a hard time. They were depressed, they were cutters. They self-harmed with blades, because I don't think we're allowed to use cutters anymore. I don't know. I don't know. Maybe that's just an inpatient psych thing. You're not supposed to use that terminology, but I'm not inpatient psych anymore. So a lot of them talking with me, and I was talking with them about it, just kind of helping them get through harder times, and some friends that were going through some hard times. So that piece kind of was sparking my interest. And then also, actually, I didn't want to be a nurse at first. I wanted to be a youth pastor. Go figure, right? But then my dad said, no, you're going to college. You have to have a job that you can pay your bills with. Little did my dad know is that Point Loma actually treats their Christian ministry majors very well in terms of scholarships. But anyways, not bitter at all. I had fun being a psych nurse. I can't wait to be able to do it again. And it was kind of cool, because being a psych nurse, you get to kind of do the one-on-one stuff that a youth pastor does with a kid. They talk with you about what's going on with their life, what they're having a hard time with, what they're struggling with. One good way that I always would word it is hey, do you guys believe in any religion or higher power kind of thing? What do you guys believe with that? And so that would usually spawn and the kids be oh, I'm a Christian, blah, 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 blah. And I'd be okay, well, does that bring you comfort? Do you talking about that stuff? And 3/4 of the time they say no, but then the quarter of the time you get that kid that says, yeah, I'd like to have a conversation about it a little bit. I'm not saying I'm doing conversion calls or anything like that. It was just conversations about life sucks right now, especially for you, because these teenagers that I worked with, I'm totally sidebarring into something else, but the unit that I worked on, I had the Medi-Cal contract, so county insurance contract, and then we also took private insurance. So you had this dichotomy of patients. You had these kids that were beaten the crap out of every day, super depressed and stuff like that, and then you have the kid come onto the unit that's I'm gonna kill myself because my mom and dad took away my phone. It's when we play dodgeball later, I'm aiming for you. Come on, man. It's a phone. This is ridiculous. There's more studies to be said about that. But kind of back to what I was talking about. And yeah, it was always something really interesting, because even I did some missions work a little bit when I was younger, and in high school, and I always saw this interesting, or outreach and homeless cleanup stuff. I always saw this interesting, I just always found it interesting, it's not even a new field. It's just a field that people are actually paying attention to now, especially now in pandemic mode. I was hearing some people talk, and I think some statisticians are going to be putting suicide as one of the top 5 leading causes of death in adults, if I remember right. Like in this next go around for statistics to come out.
I know
Uh,
it's skyrocketed, but I didn't know
it's
specific
it's
stats.
going to be one of the leading causes of death, like
Wow.
coming up in the next bout of statistics, because it's always hung out in like the 20 plus like areas of cause for death, but I think it's like up to in the 10 plus bracket now, so it's like actually pretty common. So like it's like this new, like, it's not, like I said, not even new, but like people are like starting to talk about it and like start looking at implications in like society and like the different psychological things and psychiatric things involved with that. And it's just been really interesting. It's like, it was a fascinating field for me. And like, all you really do is talk. You don't have to worry about your patient. Like, and another big reason I chose it was like, if I accidentally make a med error, odds are this kid's not gonna die. They might feel a little queasy, but they aren't gonna die. It's great. Whereas if you're in like med surg or emergency medicine, oops, I gave epinephrine instead of something like Benadryl. Like, oh crap, this person's gonna have a heart attack. So you don't have to worry about that as much in psychiatry, which is fantastic. And plus, like I said, all you really do is like talk and kind of counsel, depending on what style of psych nursing you want to take. Because there's the psych nurse that'll be in there talking with the kids, not just about their assessment stuff, but also about like life stuff, or like in there interacting with kids. And you'll have your psych nurses that are like, I'm gonna sit in the nurse's station, I'm not gonna do any of that, I'm just gonna do my assessment, that's it.
Yeah.
Like, okay, well, your patients aren't gonna like you very much. I mean, it's not about like who your patients like, because odds are if you have a borderline patient and that patient loves you, there's like one of 2 things that you're doing. You're either doing something really right or something really wrong. The thing that you're doing right is you would be setting firm boundaries. You're adhering by those boundaries, and like you're kind of like, like, and it's kind of like the tough love kind of thing.
Yeah.
Or they manipulate the crap out of you and they can get whatever they want out of you. So it's like, it's either you're doing great or you're doing awful. There's no in between with a borderline patient. So it's such a different field of nursing. And like it was kind of also appeasing that I didn't have to wear scrubs. Like I could wear like pants and a shirt if I really wanted to, or like a business casual shirt, and that was fine. Like that was dress code, totally okay.
Oh, interesting.
Yeah, like because I mean, if you think about it, like a reason that nurses wear scrubs primarily is like like they're fluid resist, like bodily fluid resistant, or they're like all that stuff resistant. Where I mean, like in psychiatry, like, yeah, you might have one person fling feces at you once in a blue moon, but or try to pee on you, but that's really about it. Like you're not gonna be flinging blood everywhere, or like pulling out catheters, flinging the urine all over the place. Like, and odds are you can get out of the room and close the door before they can even get the stream on you. So I mean, there's there's some good. So yeah, and plus just another piece of mental health is like you are. Physically, the person may be okay, but mentally, that person's hurting so bad, like so bad, and they are literally at the end of their rope, because odds are the reason they're with you and on your unit is because they tried to kill themselves. Like there's those people that are like serious, like actually have serious attempts, and like the people that are like, oh, I took 3 Benadryl. I'm like, you're just gonna sleep for 12 hours. That's not gonna kill you. Like, come on, like. So yeah, it was a big, wide, like life stuff, and like leading into that, and plus in college it's rough. Like I had my own bout of mental health stuff, and I like saw a counselor and was like, this is like really helpful. I'd like to be able to kind of like iterate this, like for other people, and like I've always wanted to work with teenagers because teenagers are fun and also don't hit as hard most of the time. So. Yeah, I think that was a very long, drawn-out version of why, and there might be some other stuff that comes up with about why I chose psychiatry, but that's a big reason why I chose psychiatry.
That's great.
Yeah.
And the psych field itself is so diverse. You've got inpatient and you've got even outpatient, whereas outpatient, they're not as severe. They can be at home and then come back in for treatment, but when they're with you or in the hospital, that means they are very critical stage and require intensive treatment and observation. Could you kind of dissect some of the differences of the spectrum? Because I know some hospital units aren't as strict as others, and kind of what are some of the different options you can have as an inpatient psych nurse?
Yeah, so in terms of inpatient psychiatry, like sky's the limit in all realities, because you can have your medical behavioral units, which is, you know, like eating disorders. So you'll still have that medical piece, but you're still dealing with that psychiatric piece. So if you like the best of both worlds, it's like, hey, medical behavioral, or is this a geropsych, like old people psych? So much fun, but it also feels like you're working like at a med surg unit because you have to do so many different random procedures. But also like after you're done with those procedures, you can go swing dance with the like 85-year-old in the day room. It's great.
Oh, fun.
Yeah, it's, you know, like, so there's Jerry Psych or Gero Psych, which is, you know, like your older people psych. Also has a lot more medical influence as well as psychiatric influence as well. So you have to be a little bit more, if you want to do that, you have to be like, yeah, I want to work with grandma and grandpa, or after their spouses died and they're feeling really depressed, or their dementia is really bad or something like that. So there's that. There's chemical dependency recovery. So there's it's more of a voluntary inpatient unit, whereas if like I'm going off of the one unit that I've seen, that because, you know, being an instructor, I had students go up onto that unit to, you know, do work on that unit as a nursing student.
Yeah.
So that's like a voluntary unit where you like check yourself in, be like, yeah, I need help with my chemical dependency problem, and this is like a spot where you can like go through like a detox program, but then they're going to set you up with like an additional, like if you really need that extra step, that residential kind of setting, like where you see like those Malibu resorts or whatever that are like drug rehabs, like the one that you see advertised on TV for like Malibu or Thousand Oaks or whatever. Just like, this seems way too expensive, but anyway. So there's that. And then you have your varying degrees of intensity. So like, I'm just going to go back to the adult hospital that I worked at as a professor. They're like your ICU setting. So that's your super acute psychiatric patients. So we're talking like super suicidal patients that are like looking for anything and everything they can use to kill themselves. We're talking mania patients, and for those of you who aren't familiar with mania, your brain don't turn off. It's the easiest way to put it. And it goes up into fantasy land, and you just have like these random delusions. Super fun to have a conversation with a manic person if you ever get the chance, and they're not aggressive. You will learn very intimate details about whoever the president is and how they go golfing with them on every Thursday. That seems to be a pretty common thread, actually, a pretty common one in psychiatric cases. So you have like your manic patients, you also have your actively psychotic patients as well, where, you know, or aggressively psychotic patients, because like you can be pleasantly psychotic and they'll put you on like kind of like a step down acuity unit. So like it's still locked, but, you know, like you can say some sassy comment and they'll just be like, wait, what? And then they'll just completely forget about what they're going to do. So like that's kind of like your ICU setting. That's when you're going to have like your more aggressive type patients, you know, patients that when you hear the horror stories of psych nursing, that's going to be on the ICU.
Okay.
In terms of horror story of patients, horror story nursing staff will be just about anywhere in psychiatry, because there's this interesting this interesting idea of psychiatry of, oh, just suck it up, you'll be fine. You know, like, where that's not necessarily accurate.
Yeah.
Like there are some cases, like, because, you know, we can dive into the different types of depression. Like there's situational depression, whereas when the situation starts to resolve, you start to notice you feel better. Like that's great for like processing that in therapy. And then you have like your major depressive, where there's an actual physical hormone lack in your brain. Have like a major depressive disorder. Like your brain actually legitimately does not produce enough serotonin for you to be able to feel emotions to the degree you're supposed to be able to feel emotions. So there's like some people, you can like, your situational depressed people, you're like, all right, come on, let's go for a walk. We'll talk about it on the walk or whatever. Like, you know, like talking with them, but also getting them out of their room and out of the dark hole that they're keeping themselves in. Yeah. So, I mean, that's like kind of like your ICU setting. You get super delusional, super aggressive patients for the most part. You'll get kind of like your step down units where, you know, the person's suicidal, but they're like, you can give them a blanket and they'll be okay. Like they're not going to try to strangle themselves with a blanket. You also get like your more pleasantly psychotic people who are just, they have hilarious delusions. Like, I know that's weird to say, but like you hear some of the delusions and you're just like, what? And then you also, you know, get, that's more like a kind of like, you'll see like your depressed people as well. And, you know, like, again, that's like people who are depressed, but not necessarily suicidal. Because there is that kind of a fine line between being depressed. Well, not even a fine line. There's like, you're either depressed or you're suicidal. Like you can be both, or you can be one or the other. Like, you know, because suicidal ideation does not always equate with depression. And then like you have just general med psych units, where you might have like a more medical patient who also needs more psychiatric support. So there's like those meta psych units, is kind of what they're called. There's also like your psychiatric ER situations as well. So a psych ER would be like you're in the ER setting, they get medically cleared and they get taken over to a holding area or a psych ED area where they can then be placed with resources or get discharged with resources or have whatever their plan of care is for that person who's in with you. So there's also that, which that's also a very different type of psych nursing as well. So I've worked in that kind of a field as well, because the hospital I worked at before where I work at now just had opened up one, and it's a little bit different, because you know that's usually a faster turnaround of patients, because it's like an ER. So like, you know, admitted and discharge a patient within 2 hours, like within an hour, like, so it's a little bit different if that's kind of something you're looking at. And then obviously you have like some more specialties, like there's child psych, there's adolescent psych, there's child adolescent psych, which is, you know, the same as child psych and adolescent psych, just on the same unit, which is an awful mix. I can confirm that one, because it's hard when you're a nurse for a 7-year-old and a 17-year-old who are in for very different things.
Okay.
It can be a little bit more, let's see, I've got a suicidal 17-year-old and I've got a 7-year-old who's just aggressive and just needs some tough love, to put it nicely, and some discipline. So it's like you have these two polar opposites, and that can be a little stressful, which is nice when they have separate child units and separate adolescent units, which, as there's more of a rise in awareness of mental health, I think with childs and adolescents, I think you will start to see more split units, hopefully, knock on wood, more split units for child and adolescents.
Especially if the population of those children who need mental health services rise, especially with the pandemic and being isolated and off school for over a year now. And I know childhood suicide and depression has gone up, so I'm sure that that'll end up kind of maxing out facilities, forcing hopefully a separation and growth to be able to meet the needs.
Yeah, because it's rough when you have a kid that you know you're going to discharge to juvie and you have this innocent 7-year-old on the same unit. It's like, and they have a shared common space. So that's another interesting thing about psychiatry that I forgot to mention. Yeah, they don't stay in the rooms. They're not supposed to stay in their rooms unless it's like a psych unit. They're up roaming around in the common areas outside in the outside space if there's an outside space provided. Like, it's very much because they're medically stable. So like, why do I need to keep this kid on bed rest when it's just going to do them more psychiatric harm versus letting them go outside and shoot hoops with some of the other kids? Like, because some psych facilities will have basketball hoops too, or like Foursquare, if like, you know, it's a child adolescent. Like, so that's another interesting thing about psychiatry is like, you actually do have to, like, when you're ready to go and do your assessment, you're like, okay, where exactly is my patient? They're not in their room. So by default, they're either in the day room or outside. There's no group outside, so I'm going to go look at the day room. And you're like, oh, wait, they're with the therapist. I can't interrupt that. So, yeah, that's another fun thing about psychiatry is like your patients aren't stable. No, they are stable. They're just not in the same space or same room and confined to that room. I mean, obviously, that's their room. They sleep in that room for the most part. Or not for the most part. There will be no additional patients allowed in that room unless it's like a double room, and then only those 2 patients would be allowed in that room, kind of thing.
Okay.
So like there could be like a girl from one side of the hallway going to like these 2 boys' room on the other side of the hallway, because that's no.
Yeah.
But yeah, so that's kind of another fun little tidbit of psychiatry. And I can also talk a little bit about outpatient, just because I led an outpatient clinical rotation too.
Sure. Yeah.
Yeah, the nurse role in the outpatient world depends on what outpatient you're in, because there's like your senior. So for the most part, outpatient is therapy. Like it's going to be therapy groups. They also go and they will use, and as a nurse, for the most part, if we're talking about the nursing perspective, depending on where you're at, for the most part, you're just going to be doing meds and just passing meds, doing your assessments, doing intake assessments. You're not going to be doing a ton of patient care. Now, if you're in, like, let's say a chemical dependency recovery group, you're going to be doing UTOXs, like, you know, you're in drug screens and like alcohol levels and stuff like that. You actually get the breath. I saw at one hospital I was teaching at, they had a breathalyzer and they were like, blow. It was for an alcohol group. And yeah, like that's kind of, as a nurse in outpatient psychiatry, it's like, that's what you do when you're like, in my opinion, like that's what I would want to do like towards the end of my career. Cause you know, it's like, it's a 9-to-5 job, weekends and holidays off. It's usually a Monday through Friday thing. Like it's, you know, a little bit more hands off in a sense. Okay. So if that's your cup of tea, good for you. But at the same time, good luck getting one of those jobs, because when you get one of those jobs, you usually don't let it go. Because one of the easiest and nicest nursing jobs I've ever seen.
People don't want to leave.
Yeah. And usually pays pretty good too. So, you know, there's that. Nurses are there for passing meds, and that's about it.
Life is a winding road, no telling where it goes.